All right, welcome everyone to today's webinar. My name is David Kanashko. I'm the Director of Education and Training. I want to make sure that everyone can hear my voice okay. For the most part, when I asked earlier, everyone said they could hear loud and clear, so I'm assuming that there's no issues, but if there are, you can type that in and we can see what we can do. So again, welcome to this year's first webinar of 2017, and the topic is, as I mentioned earlier, on neck pain. Actually, before we get started, I want to do a bit of housekeeping. Remember that I'm always going to ask you if you have any questions, so type them in as we go along. I won't address your questions until the very end of the webinar when I have some time to look at them, and I will comment on them as well. So please make it interactive and ask any questions that you have, preferably keeping it relevant to today's webinar. So I'm going to briefly discuss the etiology of neck pain. I'm not going to go into any depth on it, but I want to just review all the potential conditions that can cause pain in the neck. Then I'm going to talk specifically about targeting and treating neck pain with low-level laser therapy. I'll present a bit of research on neck pain. Actually, there's a fair amount of research on neck pain and low-level laser therapy, so I'm just going to touch on a few research papers that are quite good. And then I'll end up with talking about specifically our BioFlex cervical spine treatment, about the protocols, and specifically about what seems to really work well for us here at Meditech, and I want to pass that knowledge on to some of our users as well. So some of the common etiologies of neck pain. First of all, we need to understand that neck pain is very prevalent in today's society. The latest figures I got was from the U.S. Burden of Disease collaborators, and they say that's the fourth leading cause of global disability and has an annual prevalence rate of exceeding 30%. So I've seen numbers anywhere from 30 to 40% as far as prevalence of neck pain. So it is a very common problem, and it's something that a lot of our users use our equipment for. So I think it's a really good topic to start the year off with. Some of the common causes that cause neck pain, everyone's familiar with cervical acceleration deceleration, or whiplash. That's the fancy name of saying whiplash. And other trauma, sports injuries and other falls, that kind of thing. Osteoarthritis, one of the most common causes of neck pain, which of course can cause stenosis and degenerative disc disease, foraminal encroachment on nerves, spondylosis, and so forth. Rheumatoid arthritis, stress, meaning emotional stress, mental stress at work. Not that I've ever experienced that myself. Prolonged posture, for example, sleeping awkwardly can oftentimes trigger neck pain. Referred pain, of course, from muscles around the area or other areas that might be injured or diseased. Muscle strain, again, usually due to sports injuries and so forth. Disc herniations, torticollis or wry neck, fibromyalgia, and I'm sure there's a few more that I missed out, but those tend to be the more common ones that sort of walk into our office complaining about neck pain. Less common causes of neck pain, and ones that we should all be familiar with respect to differential diagnosing and making sure that our patient doesn't have any serious conditions, would be things like a coronary artery dissection, which is obviously a very serious condition that can cause neck and headache pain, head and neck cancer, retropharyngeal abscesses, epiglottitis, acute coronary syndrome, that is referral from the heart after myocardial infarction, congenital cervical ribs, AS or ankylosing spondylitis can cause neck pain. Of course, fractures to the neck. All right. Esophageal trauma, subarachnoid hemorrhage. So these tend to be more rare, but of course, potential causes of neck pain that we all need to make sure and rule out as far as red flags when you do your initial history and examination. So depending on the symptoms and the cause of neck pain, that will really dictate how we're going to treat using laser therapy, specifically the laser probe. So for example, if the issue is more nerve compression, then we want to target the laser probe more with neural targets. For example, that might be the nerve roots or the posterior ramus of the spinal nerve. Tender facet joints, this is a very common problem in the neck causing pain. So we want to make sure that we accurately locate and treat the articular pillars, both from the anterior and posterior aspects using the laser probe. I'll review that shortly. Of course, there's muscle tenderness, so we want to make sure that we treat both locally and distally if there's any trigger points that are referring to the neck, like the later scap and so forth. So let's start with targeting nerves. Specifically, one of the most commonly affected nerves for neck pain is a medial branch of the dorsal ramus. Sorry, I'm having some technical problems with things that keep bouncing up. So basically, these nerves are relatively superficial at each dermatomal level, so you need to make sure you can locate the specific dermatomal level, and of course this can actually create a nerve blocking effect. So in other words, if you have the probe on there long enough, you can create a temporary analgesic effect and therefore actually help block pain temporarily. So this dorsal ramus supplies the articular branches to the facet joints. So obviously if there's facet pain, it's mediated through this nerve. And it also supplies the periosteum of the vertebral arch. It supplies autonomic in the form of visceral motor and somatic motor, as well as sensory information from the skin and the deep muscles of the neck. So it's a really important nerve that runs posteriorly along the spine that can cause neck pain. So you need to understand approximately where it is and target that with your laser probe to help with neck pain. Neck pain, specifically due to facet involvement, can occur in as many as 36 to 67% of patients with neck pain. This is taken by Nicholas Bogduk. He's one of the world leaders in spinal pain. And facet joints, as you know, are diarthrodial-synovial joints with fibrous capsules that are richly innervated by both proprioceptive and pain fibers. So facet joints should be one of your targets for neck pain because they tend to cause a lot of that presenting pain in patients. Remember that facet joints, or the articular pillars, are roughly 2.5 centimeters lateral to the midline in the back of the neck, to make sure that you locate them accurately when you're using the laser probe. And remember that the articular pillars at C5 and C6 are the most commonly affected in osteoarthritis. So when you're treating patients with OA in the neck, be sure that you isolate C5 and C6 specifically to try and target those facet joints fairly significantly. Remember, when you're using the laser probe, you should be applying overpressure as long as the patient can tolerate it. So when you're putting the probe onto the patient's skin, push in until it depresses into that skin at least a centimeter or so. This allows the laser probe to actually get closer to your target, for example, the nerves and the facet joints that I've just mentioned, and allows better depth of penetration and more dosaging to the area because you're pushing the blood away from the area as you push the probe in. Okay, so this is a really important tidbit of information that all practitioners should be employing when they're using the laser probe. Another little reminder is make sure that the laser probe contacts the skin in a perpendicular fashion as opposed to at an angle shown here on the right. So if it's at an angle, you may not make good contact with the skin. Some of the light actually may bounce off and reflect off the skin, and therefore decreasing the dosage to the deeper tissues. So it's all about getting the light to the deeper tissues and having both an analgesic effect and an anti-inflammatory effect and a repair effect as well. So typically when you're treating the back of the neck, now again, I'm focusing more here on the laser probe right now. I'll talk about the arrays shortly. You want to start superiorly. Usually we start around the superior nuchal line, suboccipital region of the neck, and make our way down, excuse me, or side to side in a grid-like fashion, inferiorly and peripherally as you feel that you need to. So it's easier to do it this way than sort of go all over the place, because then you may actually treat one area too much or too little, and again, may not necessarily have the best effect because some areas that require the dosaging maybe you've missed or didn't spend enough time with. Make sure you treat the insertions at the occipital nuchal line, especially for headaches. So when you're using our headache protocol, it's basically the same as our neck protocol, with the exception of treating a little bit higher up and spending more time at this occipital or suboccipital region. Ensure that you treat the origins and insertions of muscles, for example, levator scapulae or even the traps. They're very important triggers of neck pain. You want to treat around the shoulder girdle. I'll talk about this shortly. And of course, as I've mentioned, the articular pillars, which for the average person roughly lie 3 to 5 centimeters deep. So in other words, you can easily reach the articular pillars with infrared light because the general consensus is the depth of penetration for infrared is anywhere from 2 to 5 plus centimeters. So it is easily achieved using a laser probe in the infrared wavelength. Don't forget about trigger points that refer to the neck, whether they're in the sternocleidomastoid, levator scap, and so forth. So make sure you spend some time on trigger points. In fact, you can actually use a laser probe much like you would be using your thumb and push in on the trigger point to deactivate it both with light and with actually the pressure of the probe. It's also important to take a look at the anterior neck just in case there's any structures that are referring pain or causing neck pain itself. When you're treating the front of the neck, make sure you're not treating the thyroid gland because that is contraindicated for light therapy. Typically, you're going to be treating the sternocleidomastoid. That's one of the major targets for neck pain, okay, especially in cases of torticollis. And another target that you may or may not be aware of is a stellate ganglion, which is an autonomic nervous system gateway. And it's very important when patients have certain autonomic nervous system symptoms. So for example, if a patient has complex regional pain syndrome, Raynaud's, excessive sweating, unexplained pain in the face, including headaches, herpes zoster, and so forth. Actually, I have excessive sweating twice. Maybe that's because I'm excessively sweating or something. But anyway, what you want to do is actually target this ganglia in the front of the neck using your laser probe. So it's located essentially where the first rib articulates with the spine. Okay, and you can actually, and that's just above the where the sternoclavicular joint is in the first rib. And you can apply that probe roughly where the, I think it's the lateral margin of the sternocleidomastoid, and put your probe in there, and you'll target that stellate ganglion, and you may actually have some good success with some of these autonomic nervous system symptoms. Don't forget about targeting the brachial plexus if there's issues with nerve involvement. Okay, so again, you need to know roughly where the brachial plexus is traveling, both superiorly and inferiorly, and as it enters into the shoulder girdle, as I've shown here in the diagram. Okay, so if your patient's also experiencing neck pain with radiculopathy, you want to understand where the pain pattern is, C5 to C8, and treat the nerve root that is associated with that specific radicular-like pain. Okay, now a bit about the research. I've mentioned Roberta Chow many times in past webinars and at our training. Roberta Chow being a physician and a PhD out of Australia. She uses laser therapy for her neck pain treatment in her clinic. And she wrote a meta-analysis on neck pain and laser therapy. And she was quoted in this article saying that we, meaning her and the other authors, including Jan Bjordal, we show that LLLT reduces pain immediately after treatment in acute neck pain and up to 22 weeks after completion of treatment in patients with chronic neck pain. So from all the research that she looked at, the findings were that it's very effective for acute neck pain, which is usually what is very worrying for patients that come in where they can't move their neck and they're in a lot of pain. And that what's really interesting is the effects last up to 22 weeks after treatment. So it has a long-term beneficial effect in actually helping resolve that neck pain itself. This is a really great paper. If you want more information on it, please contact me and I certainly will be able to help out with that. I wanted to bring you a really nice randomized control trial on neck pain, again by Roberta Chow. This is a different article, and the title here being the effect of 300 milliwatts, 830 nanometers on chronic neck pain, and it was a double-blinded randomized placebo-controlled study. So patients were diagnosed with chronic neck pain. There were 90 patients in total. They excluded certain conditions from patients that were selected. They were randomly located to laser placebo. They're the parameters of the laser, and they used a pressure contact technique that I've talked about, perpendicular orientation that I referred to earlier. So they treated, interestingly enough, 50 tender points, or up to 50 tender points, laterally and over the paravertebral tissues, including the articular pillars, in and around the neck, as well as the sternocleidomastoid belly, insertion at the sternum and the clavicle. As outcome measures, they had quality of life questionnaires. They used the Northwick Park neck pain questionnaire, a neck pain and disability scale, McGill as well, and the VAS scale. So when the patients first presented and then were treated with laser or placebo, they roughly had pain at around 8 out of 10 on the visual analog scale. And after 12 weeks of treatment with the laser control group, they actually had that improved by up to 2.7 on average, so down to about a 5 from an 8, which is significantly or statistically relevant. So very good results for that. So they concluded essentially that laser therapy of this wavelength and approximate dosaging or energy density provides clinically relevant benefit in management of chronic neck pain as a monotherapy. Okay, so again, imagine if you actually did some manual therapy, some traction, some other techniques, the effects are even that much better. They also concluded that laser therapy has low incidence of adverse effects, which is really important, especially if a patient can't tolerate manipulation or too much hands-on work, especially in the acute phase, and of course is relatively easy to administer. All right, so let's talk a bit about our specific treatment with respect to frequency. Usually we start treating right away, and we try and treat 3 to 4 consecutive days if possible. This is really important if a patient's in an acute presentation. We then move to 3 times a week, every second day during the following week or 2. Then we start to treat about 2 times a week and until they've reached maximal medical recovery. So again, when we're treating with BioFlex laser, we want to make sure that we're treating the appropriate area. So again, even though we're talking about neck pain, you want to make sure you cover the tissues that may also refer to the neck as well. So the posterior shoulder girdle area, both posteriorly and laterally, you want to make sure you cover that with the actual superluminous diode array or our dual array. And then when it comes to the actual laser probe, which is what these semicircles are indicating, that's when you use to target those tissues I mentioned earlier, like the facet joints, like the nerves and the discs and so forth. Okay, so we're treating all of the areas, then we're going to hone in on the specific targets right in on the neck, and then of course you can migrate on trigger points if you specifically want to target those as well. Okay, so for the array, our standard array placements are in A, treating the suboccipital region down to about C4 or C5. Then we do another position transverse, we call it, which goes from about the C4 or 5, although that doesn't really accurately show in the diagram, to roughly T1 and T2. And then C and D show lateral placements that we're trying to cover more, the nerve roots and the erector spinae on the side or lateral aspects of the neck. So let me go over our protocols and give you a bit of information what we've been doing in our clinic and been finding it very successful, and a bit more clinical guidelines for treating the neck. The stage 1 protocol in our manual has the red portion of the SLD or the dual array at continuous wave and showing you 6 minutes, those 4 placements. What we've been doing is we've been finding that the dual, now these 6s were our original time frames for our first generation array. What we've been finding is the output of our red SLDs are quite good. They don't degrade over time. So we've actually been using 5 minutes instead of 6 minutes for the red. Okay, so this will save you about 4 or 5 minutes of treatment time, maybe get the patient out a bit quicker. And we've been finding that the patients are responding actually very well to that. The first stage has 10 cycles per second and 20% duty cycle, showing you 6 minutes for the infrared. And I do really recommend that you start at 10-20 or pretty low when the patient presents in an acute or a subacute presentation. However, if a patient presents in a chronic neck pain scenario, the pain isn't too severe, you can start higher, even up to 50-50 in the infrared. Okay, so once again, make sure that you start low as recommended in acute or subacute cases. But if a patient is coming in with low-grade lingering chronic neck pain, usually you're okay with going up and starting at a little bit higher rate, 50-50, which actually is pretty close or is actually stage 2 for the infrared. The laser probe, make sure it is set to 40%. You can treat anywhere from 6 to 9 minutes, covering those targets that I mentioned earlier. One thing I should note is cervical spine patients can be very sensitive to laser therapy, especially the acute cases. So make sure that you're prepared to lower dosages, especially in the laser probe, if the patient has persistent aggravation of treatment after the treatment. If the neck pain patient responds negatively, then just adjust these parameters a little bit lower. So for example, if you started at 50-50 and for some reason that's aggravating the patient after 2 or 3 sessions, drop it back down, okay? In some cases, you may avoid using the laser probe entirely when you first start to treat. So in other words, if a patient's really sensitive to treatment, even at the lower 10 hertz, 20% duty cycle, skip the probe, just use the arrays, see how they start to respond, and then eventually you can reintroduce that laser probe in future treatments as the patient can tolerate it. So again, I want to make sure everyone understands that cervical spine patients, when you treat the neck, because the tissues are highly innervated and very easily exposed to the light, make sure that you use the lower dosages, be aware of any patients that are being aggravated, and adjust your parameters accordingly. So in order to adjust the dual red from 6 minutes to 5 minutes, you'll have to customize your protocol. So if you do that, you can save this revised protocol for future patients so that you actually don't have to redo that every time a neck pain patient comes in. For stage 2, we typically start to modulate the red at 190. Again, for the dual array, you can go with 5 minutes instead of 6 minutes per placement, and 50-50 or thereabouts is the stage 2 protocol. Notice that the probe is 100% in stage 2, but I'd be careful with that. You may want to increase it in increments from 40 to 50, 60, 70, 80, 90, up to 100, as opposed to jumping right from 40 to 100. And then into stage 3, the infrared goes to 50-80, and the probe again is approaching 100%. The red is modulated at a higher frequency at 250. So you can see that for cervical spine protocols, we tend to actually have much lower frequencies than other areas of the body, again, because they tend to respond and tend to be a little bit more sensitive than other areas. All right, well, that's our webinar for today. I'm going to open up to questions right now. As I do that, I want to remind everyone that we are having a masterclass in Toronto at the MasterCard Center, just around the corner from our 411 Horner Avenue clinic in Toronto. And our guest speakers will be Dr. Fred Kahn, who's coming out to talk about his experiences with what is now over 25 years of BioFlex clinical success. And we're also bringing in from Halifax, one of our most experienced and probably the second largest laser therapy clinic in North America. That is our famous Dr. Ben Ewan. From Halifax, if he's listening in or his team is listening in, thank you very much, Dr. Ewan, for coming out here and being part of this event. Ben has been using our equipment for well over a decade, has had great clinical success, thinks a lot outside of the box, and specifically we'll be talking about not only interesting case studies, but how to manage patients that perhaps aren't responding the way you'd like. Perhaps they are maybe being aggravated by laser therapy, how to approach that, and some really other common things that as clinicians start to use our equipment, they start to have questions about. Dr. Ewan has had a tremendous success out there treating many different very interesting conditions, and he's going to bring that experience to Toronto on May 13th on a Saturday. It is a CE hour event, so if you do need structured hours, the chiropractors or the massage therapists out there, it's a great event to get that as well. Please go to our website under events and you will see the registration process. We do have an early bird registration. I believe it's $199, so it's a great savings from the standard $299 fee. So let me get to our questions right now, and let's see what we have. So I have a question from Sue, and it is about a degenerative disc in the upper neck that's causing pain, neuropathy, and headaches. And the question is with reference to using laser therapy to help heal the disc. And if it can heal it, exactly how long it will take and so forth. Now, with respect to treating herniated discs, typically they will heal. They will heal at an accelerated rate than compared to just leaving it on its own. And it really depends with respect to time frames. As far as surgery goes, they usually don't do surgery, obviously, until it just hasn't gotten any better over a period of time. But we've had a really good success with treating herniated disc, both in the neck and the lower back. It's really important that treatment is done consistently, usually 3 to 4 times a week, and it does take several months for that to resolve on average. Another question is, how does BioFlex work to increase mobility of the neck? Well, it's going to be doing this indirectly, Susan. So essentially what it's going to be doing is reducing inflammation that then, of course, helps to reduce muscle spasm. By treating muscle spasm directly, like trigger points and other muscles that are holding the neck, as they release, you can obviously increase mobility as well. So along with mobility or mobilization or manipulation, it will definitely help to improve mobility. A question from Andrew. And that question is it wise to combine laser therapy with stretches, for example, range of motion stretches or strength-based when treating neck pain with laser therapy? What we typically do, Andrew, is we'll incorporate those exercises once we feel the patient can tolerate them. So initially, we'll let laser therapy do its thing. And as the patient's improving and to the point where they're able to start to do these exercises, we'll bring those in. Typically, we'll initiate range of motion first, and then add strengthening exercise a little bit later on, because that tends to sometimes aggravate the acute or subacute neck pain. Will I be able to print these slides? That's from Sheila. Good question. If you send me $200, maybe you can print those slides. No, I'm just kidding. If you want some of these slides, contact me. I can certainly get you a portion of them. I don't know about the entire presentation, though. This webinar is posted on our website under our support page if you want to take a look at it again. Another question is, our difference between BioFlex and K-Laser? Well, very briefly, K-Laser is a class 4 laser therapy device, Pedro, and it really is different. What we're talking about here is photobiomodulation or class 3 laser therapy. Class 4 laser therapy, its mechanisms of action are by heat and a thermal effect to help with circulation and pain. However, it doesn't have a photobiomodulation effect for healing and inflammation. So really, they're very different things, and I would encourage you to email me or contact me, and I can have a bit longer conversation with you about that. Question from Danielle, would you do a physical treatment before or after laser treatment? That's a really good question. I don't think it really matters personally, but if you're going to be doing physical treatment that increases blood flow, I would do laser therapy first, then the physical treatment, because blood does block some of the light from going deeper into the tissues. But we have a massage therapist here that we do manual therapy, and we do typically do it after laser, but not necessarily always, and it doesn't seem to really have any effect that we can say we advocate one over the other. Do you track data from your C-spine patients to measure outcomes and efficacy? From Clifford. Actually, that's a really good point. We actually track data from all of our different conditions. That's how how Dr. Khan comes up with his protocols and why we make changes to protocols and why we actually advocate for making changes as I talked about in the webinar today. So it's really based on our data for these patients so that we can confidently speak to them in webinars and our training. So it is definitely all tracked in our clinic. Hi, Jeffrey Sostek, long time no here. Jeffrey is a massage therapist, very successful with using our equipment. And he's asking, is there any evidence of harm done to the thyroid gland upon red light illumination? Jeffrey, there were some research papers with respect to exposure of thyroid gland to light. I don't know if it was red, it could have been infrared, and they found that it increases the metabolism of the thyroid gland, so therefore it's a contraindication to treat over it directly. So if you're treating around the thyroid gland, I would put a towel or something to block the gland if you're treating the anterior structures of the neck. But Jeff, if you want me, email me and I'll dig up those papers and I'll send them to you. Another question is, what are your outcome measures? Are they objective or subjective? Our outcome measures for neck pain are both subjective and objective. Subjective being VAS and you know, what the patient is telling us. Objective is we're going to be doing range of motion. We're going to be checking you know, other objective measurements if it makes sense to do grip strength or nerve conduction studies, that kind of thing, if there's nerves involved. So we do a combination of both objective and subjective measures for our outcomes. Question from Kelly is, I missed the treatment protocol frequency part. Can you repeat that, please? Sorry, I can't get back to it right now, Kelly, but email me and I will get that to you, or certainly you can visit our website to watch this webinar again. Remember, my email is david@bioflexlaser.com. And Evelyn asked about scoliosis. She did ask me to mention this earlier. When we're treating scoliosis, Evelyn, we're basically trying to treat the effects of that curvature on tissues that might be inflamed. So basically, it's not going to have a direct effect on the mechanical aspect of scoliosis, but it will help with potentially some of the signs and symptoms of it that cause muscle tensioning, muscle inflammation or joint inflammation, and earlier onset of degenerative changes. Question from Shelley, can it treat stretched alar ligaments? It can treat, that's a really good point. The alar ligaments are really deep. I don't know if it can directly get light to them or not, but typically it can treat ligaments. So if you can get the light anywhere close to those alar ligaments, I would definitely say it would be beneficial to help sprained ligaments of the neck. And let me see here. What about the use of ice or heat after laser therapy treatment from Mary? Really good question. I just read a paper actually on ice, cold, and laser therapy. I can't remember the outcome now, gosh. I think they actually recommended to do the ice afterwards, but now I can't remember, Mary. So you know what? If you can email me, david@bioflexlaser, I'll pull up that research paper, give it to you, because they actually did make a recommendation which was better. As far as heat goes, of course we use heat after chronic conditions, and we do that after laser therapy, not before. A question from Linda, do you have the exercises listed somewhere that are beneficial? Not specific exercises, we just tend to go by the standard range of motion exercises and strengthening that you would find on good physiotherapy or chiropractic sites. Hello, Hannah Lee from South Africa. I cannot get any visuals, although David's voice is audible and clear. Well, at least I'm audible and clear. Hannah Lee, contact me and I'll get you a copy of the webinar for sure. And by the way, Hannah Lee, we're doing, hopefully going to be out there in South Africa in September for a masterclass. I'm going to be doing a conference talk, although it's not confirmed, or I believe it is confirmed, and a training. So hopefully we get to see you out there, Hannah Lee, and maybe you can refer some of your colleagues. Any risk over arteries in the neck? Absolutely none, Wendy. Nice hearing from you as well. It is not contraindicated to treat over the arteries of the neck. It won't cause vasodilation because the arteries are too thick and too large, although it will cause vasodilation in smaller capillaries. All right, thanks everyone for joining, and we will see you next month for our webinar. Take care and have a good day.